I want you to try something for me right now. Just close your eyes for a second. Well, obviously, if you are driving or operating heavy machinery, please keep them open. But if you can, picture this scenario. It is 2 o'clock in the morning.
Oh, yeah. The graveyard shift.
Right. The rest of the world is completely asleep. The hospital corridors are, dim and quiet. But you are standing under the harsh, unforgiving glare of the operating theater lights.
It's a very specific kind of silence at that hour, isn't it? Just the hum of the machines and the rhythmic beeping of the anesthesia monitor in the background.
Exactly. And you have been standing in the exact same spot, in the same footprint, for 3 hours. Your back is absolutely screaming. Your neck is stiff. Your eyes are they're dry from staring at a monitor. And the crazy thing is, this was supposed to be the easy case.
Right, the bread and butter.
Yeah, a routine laparoscopic cholecystectomy.
Which is, for anyone who might not know the exact term, the medical term for taking out a gallbladder through keyhole surgery.
Right. And you probably told the patient's family, don't worry, it's a standard 45-minute procedure. Will be done in no time. But nothing about this is routine anymore.
That is the nightmare scenario right there.
It really is. The screen in front of you, which is, by the way, your only window into the patient's body, is a complete mess. The visual field is just full of blood. You were using the suction irrigator, trying to clear it out, but the red just keeps coming back. You are desperately looking for those landmarks you memorized back in medical school. The triangle of Calot, the critical roadmap.
And it's gone. It is completely invisible, just buried under this concrete block of scar tissue, inflammation, and blood.
Yeah. So we have a click applier in your right hand. It's loaded. You're ready to clamp down on a tube structure. But you look up just for a split second, and the registrar, the trainee surgeon who's assisting you, has gone completely pale. They have this look of absolute panic in their eyes. And the attending surgeon, the boss, who is supposedly there to save you.
They're at home.
They're at home, fast asleep in their warm bed.
You are completely on your own in that room.
On your own. And the patient on the table is the mannequin. She is a 58-year-old grandmother. She came in for a simple fix for her tummy aches, and now everything is basically teetering on the edge of a massive catastrophe.
And this is the exact moment where surgical careers are defined, not by how well you can cut or how fast you can throw a suture, but by how you think.
That is exactly what we are unpacking today. We are taking a deep dive into the difficult gallbladder. We are looking at this massive stack of resources, articles, surgical guidelines, and essentially what is a survival manual for surgeons that address this exact crisis point. We're talking about surgical bailout strategies, battle-tested mnemonics, and the mental models that separate a confident surgeon from a catastrophic bile duct injury.
And what I really love about this material is that, yes, it is highly technical. We are going to talk about very specific maneuvers inside the human abdomen. But fundamentally, this is a masterclass in decision-making under extreme pressure. It's about knowing when to stop.
Yeah, we have a massive amount to cover today. We're going to walk through a case study of a mistake that almost happened. A terrifying near miss. We're going to break down a mnemonic called F8 can't be AP, which is basically a crystal ball for predicting surgical disaster. And we're going to climb a literal ladder of decisions called SIFT cord.
SIFT cord is a lifesaver. Seriously, if you take nothing else away from this deep dive today, remember that ladder.
But let's start with the mission of this deep dive. Why are we talking about gallbladders of all things?
Well, because this surgery is the most common major operation performed around the entire world. And because it is so common, people just assume it's easy.
That is what we call the routine trap.
The routine trap, exactly. So our mission today is to give you a crash course in surgical judgment. Whether you are a medical student, a resident, or just someone who, loves high-stakes problem solving, this is for you.
Because it's about recognizing when routine has silently become incredibly dangerous. So let's go back to that operating theater. We have a specific case from our sources that illustrates this perfectly. Let's talk about the patient. Mrs. Fatima A.
Mrs. Fatima. Okay, let's profile her. She is a 58-year-old housewife.
And on paper, she looks like 1,000 other patients you might see in a general surgery clinic on a Tuesday morning, right?
Superficially, yeah, absolutely. She has a BMI of 34, which puts her in the clinically obese category. She is diabetic. And she presented with recurrent pain in the right upper quadrant of her abdomen. That is the absolute classic location for gallbladder pain.
Biliary colic.
Exactly. She eats a fatty meal, the gallbladder squeezes to release bile, a stone gets stuck in the neck, it hurts. Classic story.
So the team did the standard workup. They did the ultrasound, they ran the bloods. What did they actually find?
Well, the ultrasound showed multiple gallstones. Again, standard. But here is the first clue, the first little breadcrumb that something is seriously wrong. The gallbladder wall was thickened. It was measured at 5 millimeters.
Okay, 5 millimeters? I mean, that sounds tiny. That's half a centimeter. Why is that a red flag to a surgeon?
In the world of gallbladders, that is huge. A normal, healthy gallbladder wall is like tissue paper. It's translucent, maybe 1 millimeter thick at most. When it hits 5 millimeters, that screams pathology.
It's 5 times thicker than it should be.
Right. It implies chronic inflammation, it implies edema, which is swelling, but most importantly, it implies fibrosis.
Scar tissue.
Exactly. Think about it. If you cut your skin deeply, it heals with a scar. Right? That scar is tough, it's white, it's hard. Now imagine that exact process happening inside your belly between your organs. That thickened wall tells you that the tissue isn't going to separate easily. The organs are going to be glued together.
Okay, so that's tingle factor number 1. Your spidey sense should be tingling. What about her diabetes? Why does that make the surgery itself harder?
This is a fascinating physiological point that I think often gets missed by junior doctors. Diabetes causes neuropathy nerve damage. Over time, it dulls sensation.
So she doesn't feel pain as acutely as someone else would.
Exactly. So Mrs. Fatima might have had a severe infection, acute cholecystitis, maybe 3 months ago. A person without diabetes would have been screaming in pain, vomiting, rushing to the ER at 2 in the morning. But Mrs. Fatima, maybe she just felt a dull ache. Maybe she just thought it was really bad indigestion.
So she just stayed home.
She stayed home. And her body fought a literal war inside her abdomen. It created massive inflammation. It laid down thick layers of scar tissue to wall off the infection and protect the rest of the body. She survived it, but she had what we call silent cholecystitis.
So she walks into the clinic looking totally fine, but inside, her abdomen is a disaster zone.
It's a trap waiting to spring.
Wow. And then there was one more clue in the blood work, the ALP.
The alkaline phosphatase. It was mildly raised. Now, ALP is an enzyme that goes up specifically when the bile ducts are irritated or blocked.
So this suggests the problem isn't just contained in the gallbladder, but maybe it's in the main pipes.
Exactly. It raises the suspicion of a stone in the common bile duct, or perhaps Mirizzi syndrome, which is where a large stone in the gallbladder pushes against the main duct from the outside. It introduces uncertainty. And in surgery, uncertainty is the enemy of safety.
So fast forward. The team books her for surgery. They are in the theater. The patient is asleep. They put the laparoscope, the camera, into the belly. And what do they see?
And immediately, the trap springs. The source describes the view perfectly. The omentum, that's the fatty apron that normally hangs over our intestines, is plastered to the gallbladder.
The source actually calls it a mass of inflamed fat and friable tissue. I have to say, I hate the word friable.
It is the worst adjective in surgery. Friable means the tissue has the consistency of wet blotting paper. You touch it with a blunt instrument, and it doesn't move. It tears. It crumbles. And it bleeds everywhere.
So you basically can't see anything.
You can't see the Calot's triangle. You can't see the cystic duct. You can't see the artery. It is just a red, angry blob on the monitor.
So the registrar, the trainee, starts dissecting. He's trying to clear the fat away, but the bleeding starts.
It obscures the view completely. He uses suction, but the blood just refills the space instantly. And in the middle of this red haze, he sees a tube, a white tubular structure.
And his brain, which is totally desperate for a landmark at this point, says, that's the cystic duct.
That's the tube I need to cut to get this thing out.
He loads the clip applier. He brings it into the visual field. He is seconds away from clamping it down.
And this is the twist in the case study. The source material tells us very clearly what he is looking at is not the cystic duct. It is the common bile duct, the CBD.
He clips that.
It is catastrophic. You are cutting off the drainage of the entire liver. You are creating a stricture that could lead to liver failure, severe sepsis, major reconstructive surgery. It is a completely life-altering injury for that poor woman.
But he doesn't do it. Why?
Because of the scrub nurse.
I absolutely love this part of the story. It's the human element. It's not about the scalpel. It's about the team.
The scrub nurse, who, let's be honest, has probably seen thousands of these operations, speaks up. She doesn't scream. She doesn't reach over and grab his hand. She asks 4 simple words.
Is the critical view of safety achieved?
Is the critical view of safety achieved?
It sounds so formal, like a textbook. But it was exactly what was needed in that chaotic, moment, wasn't it?
It was a cognitive break. It forced the registrar to snap out of his tunnel vision. He had to stop doing and start assessing.
And to his credit, he actually answered honestly.
He looked at that messy, bloody field on the screen and admitted, no, it isn't.
And that one admission saved Mrs. Fatima's life.
They stopped. They converted to an open procedure. They made a bigger incision so they could actually put their hands in and feel the tissues. They found out she had Mirizzi syndrome type 2. They repaired it properly. She went home to her grandkids.
It's incredible because she wasn't saved by the surgeon's manual dexterity. She wasn't saved because he had super steady hands. She was saved by a mental model.
And a culture of safety. That scrub nurse felt empowered to speak up to a surgeon. That is the exact definition of a high-functioning team.
So this case perfectly sets the stage for the rest of our deep dive. We need to understand how to predict these nightmares before we are holding the clip applier in a bleeding field. The source gives us a really specific mnemonic to predict a difficult gallbladder. It's called F8-CAMP.
F8T-CAMP. It's vivid. It definitely sticks in your head.
It's essentially a checklist for high-risk patients. If your patient has these letters in their history, you need to be on high alert before you even scrub in. Let's break it down letter by letter. Let's start with F.
F is for fibrosis, or a frozen Calot's triangle. This is exactly what Mrs. Fatima had. The anatomy is literally frozen in a solid block of scar tissue.
Okay, A.
A is for acute cholecystitis, but the source is very specific here. It says onset greater than 72 hours.
Okay, pause there. Why is 72 hours the magic number? Why not 24 hours or a week?
It comes down to the biology of inflammation. In the first 3 days, 0 to 72 hours, the tissue is inflamed, yes. It's red, it's swollen. We call that edematous.
Like a badly sprained ankle.
Exactly like that. It's full of fluid. But here's the crucial thing. Fluid is water. You can separate water. The tissue planes, the natural anatomical layers between the organs, are still there. They're just wet. You can still dissect them safely with blunt instruments.
Okay, so before 72 hours, it's a bit messy but totally doable. What happens after 72 hours?
The body shifts gears. It stops just swelling and starts organizing. It lays down collagen. The tissues become necrotic and woody. It turns hard. The tissue planes completely disappear.
It literally fuses together.
Exactly. So if you operate on day 5, you are hacking through wood. If you operate on day 2, you are moving through water. That 72-hour mark is a massive predictor of difficulty for the surgeon.
That is such a crucial distinction. Okay, next letter is T.
T stands for thick wall, like our 5-millimeter patient, Mrs. Fatima, or trauma.
Trauma meaning like a car accident.
No. Trauma meaning previous surgery in the upper abdomen. Maybe they had a stomach ulcer repair 10 years ago. Previous surgery means adhesions. Everything inside the belly is stuck to everything else.
Got it. Moving to C.
Cirrhosis or coagulopathy. This is a nightmare combination. If the patient has liver cirrhosis, the liver is scarred and rock hard. The blood can't flow through it easily.
So the blood just backs up.
It backs up into the veins. We call that portal hypertension. You get these massive, high-pressure, engorged veins, varices, all over the gallbladder and the porta hepatis.
It sounds like operating in a minefield of high-pressure pipes.
You touch one of those veins and it bleeds torrentially. And because the liver is failing, the patient has coagulopathy, meaning their blood doesn't clot properly, so it bleeds, and it will not stop.
Terrifying. Okay, the second A.
Aberrant anatomy or adhesions. Some people are just born with weird plumbing. Maybe their cystic duct winds around the back of the common bile duct. Maybe it joins the left hepatic duct instead of the common. You have to assume the anatomy is weird until you have definitively proven otherwise.
Always assume it's a trap. All right, M. The source calls this one a paradox.
M stands for Mirizzi syndrome, which we've touched on. But it also stands for male sex.
Yeah, you have to explain that.
Yeah.
Why are men a difficult category for gallbladder surgery? Is it a biological difference?
It's partly biological, but it's largely behavioral. The male paradox is a really well-known phenomenon in general surgery. Men tend to delay seeking medical care.
Ah, the tough guy syndrome.
Precisely. They ignore the pain, they pop some painkillers and push through it. So a woman might come into the clinic after her second gallbladder attack. A man might come in after his 20th. By the time the man finally hits the operating table, the disease is much, much more advanced. The scarring is way denser.
Is there an anatomical reason too, though?
Yes, there is. Men tend to have more visceral fat, that hard internal belly fat that packs around the organs, compared to women who might have more subcutaneous fat under the skin. Visceral fat takes up physical space inside the abdomen. It makes the angles way tighter. It makes it much harder to physically manipulate the laparoscopic instruments.
So if you look at your patient list and you see an obese male patient, you know it's going to be a real workout.
Absolutely, you buckle up.
And finally, P.
Previous pancreatitis or portal hypertension, again, these are markers of a hostile abdomen. Severe chronic inflammation that has fundamentally altered the landscape you have to work in.
So that is FAT Campion P, fibrosis, acute cholecystitis over 72 hours, thick wall or trauma, cirrhosis, aberrant anatomy, male sex, previous pancreatitis. It's your early warning system.
If you check the patient's chart and you see an F, an A, a T, and an M, you go into that room mentally prepared for war.
Now, let's say you are in the room, you've made your incision, you are looking at the gallbladder on the screen. We really need to talk about the #1 danger sign once you are inside.
Failure to achieve the critical view of safety.
The scrub nurse mentioned it. It saved Mrs. Fatima. But let's actually define it for the listener. What is the critical view of safety?
It is the holy grail of gallbladder surgery. It was popularized by Dr. Stephen Strasberg in 1995. Before that paper, surgeons relied on just identifying anatomy kind of loosely. Strasberg said, no, we need a rigid, objective standard.
And the absolute key thing here is that it is binary.
Yes. This is the single most important concept to grasp about the CVS. There is no such thing as a partial critical view of safety. You can't be kind of pregnant, and you can't have kind of a critical view. It is pass or fail, nothing in between.
So what does a pass actually look like? Our source gives us another mnemonic, 2 in, 1/3 out.
Let's visualize this together. Criteria number 1, the hepatocystic triangle. This is the anatomical space bordered by the gallbladder, the cystic duct, and the liver edge. It must be cleared of all fat and fibrous tissue.
You have to strip it completely clean.
You need to see the white space. You need to be able to look right through that window and see the liver sitting behind it. If there is still a blob of fat there, you fail. You do not have the view.
Okay, criterion 2, 1/3 out.
The lower 1/3 of the gallbladder must be separated from the liver bed. You literally have to lift the bottom of the gallbladder up off the liver.
Why is that specific step so important?
Because it proves that the structure you are holding with your grasper is actually the gallbladder and not some other organ or dilated duct that happens to be stuck to the liver. It gives you that 360-degree circumferential view of the base.
Makes sense. And criterion 3, 2 wins.
Only 2 structures should be seen entering the gallbladder. One is the cystic duct, one is the cystic artery.
2 things connected to the bag, nothing else.
Exactly. If you see 3 structures, stop. If you see one big, thick structure, stop.
Wait, why would you see one big structure?
That brings us to the classic error in laparoscopic surgery, the visual illusion known as tenting.
Help us visualize this, because it's crucial. Why do highly experienced surgeons routinely mistake the main bile duct for the cystic duct?
Imagine you were setting up a camping tent. You grab the canvas in the middle and you pull up the center pole. What happens to the floor of the tent?
It gets pulled up into a cone shape.
Right. Now apply that exact physical principle to surgery. You grab the gallbladder with your forceps and you pull it up toward the diaphragm to get tension. If the cystic duct is unusually short, or if it's heavily scarred and contracted, pulling the gallbladder will drag the common bile duct right up with it.
It literally kinks the main pipe.
It kinks it into a sharp V shape. And to your eye, looking at a 2D flat screen monitor, that V looks exactly like the cystic duct entering the base of the gallbladder.
So you think you were just clipping the small branch, but you were actually clipping the main trunk of the tree.
Exactly. You clip straight across the base of that tent, and you have just transected the common bile duct.
It is terrifying. It's not clumsiness, it's literally a naturally occurring optical illusion.
And that is exactly why the critical view of safety requires you to separate that lower third. If you peel the gallbladder off the liver before you apply any clips, the tension is released. The tent collapses. The common bile duct falls back down to where it belongs, and you suddenly realize, whoa, that wasn't the cystic duct at all.
It reveals the actual truth of the anatomy.
It reveals the truth. It is the only way to be sure. It's exactly like thyroid surgery. You have to define the recurrent laryngeal nerve before you divide any tissue. You have to see it to save it.
Okay, so let's put you back in the operating room. FACMP predicted a really tough case. You are inside. It is incredibly messy. You are trying your hardest to get the critical view of safety, but you just can't. The tissues are frozen solid. You are stuck.
This is the danger zone. This is the exact moment where patients get hurt.
What do? You don't just keep digging blindly into the fat.
No, you stop digging. You start climbing the ladder.
The bailout ladder. And the mnemonic from our source for this is SIF cord.
SIF cord. This is your step-by-step systematic guide to getting out of trouble safely.
Let's start with the first rung of the ladder.
S. S is for stop and reassess.
It sounds so incredibly simple. Just stop. But why is that practically so hard for a surgeon to do?
Because surgeons are, by nature, type A personalities. We are fixers. We are trained to finish the job we started. There is a massive psychological momentum in the operating theater. You think to yourself, I just need 1 more millimeter of clearance. I just need to clear this one little bit of fat and I'll see it.
It's the sunk cost fallacy playing out in real time.
Exactly. But S demands that you physically stop moving your hands. Take your foot off the pedal. Take a deep breath. Step back from the operating table. Reset your eyes. Ask your assistant, what do you see here? Tell the nurse to call a senior partner into the room for a fresh set of eyes.
Just that pause, just breaking that momentum, can be the difference between a safe bailout and a catastrophic injury.
Absolutely. It breaks the tunnel vision. It forces your brain out of the fight or flight response.
Okay, you've stopped. You've thought about it. You've called for help. What is I?
I is for infundibular technique. This refers to dissecting straight from the neck of the gallbladder, the infundibulum.
But the source has a massive warning label on this one.
A giant flashing red warning label. It calls this a last resort.
Why? If that's where the duct is, why is it dangerous?
Because in a difficult gallbladder, the neck is the absolute epicenter of the pathology. That's where the giant stones are impacted. That's where the inflammation is the absolute worst. That's where the anatomy is totally distorted by scar tissue.
So you start digging your instruments in there.
You are quite literally poking the bear. You are blindly working in the most dangerous square inch of the human abdomen. So I is on the ladder because it is a known surgical technique, but in a fat Campi case, a truly hostile gallbladder, you probably want to skip this rung entirely.
So where do we go instead?
F. F is fundus first, also known as the top-down approach.
So you basically flip the surgery upside down.
Yes. Normally we work from the bottom up, identify the duct, clip it, cut it, and then peel the gallbladder off the liver. But if the bottom is a solid block of concrete, you go to the very top.
To the fundus, the dome of the gallbladder.
The fundus is usually the safest, most pristine part. It's far away from all the dangerous ducts and major arteries. So you grab the top dome and you start peeling the gallbladder off the liver bed, working your way downwards.
What's the best analogy for this?
It's exactly like peeling a banana. You start at the top tab and you peel down towards the stem.
Why does that actually help you safely find the duct, though?
Orientation. As you peel the gallbladder down, the organ itself acts as a physical map. It physically leads you straight to the cystic duct. By the time you get down to that dangerous inflamed triangle, you have already mobilized the entire organ. You can see things from a completely different angle. It often just turns the lights on for you.
Okay, that makes sense. So you try fundus first, you peel it down, but you get to the bottom, and it is still a complete mess. It is still a solid block of scar tissue. You cannot see the ducts safely. You cannot get the critical view. What is T?
T is top it. Or, in proper formal surgical terms, a subtotal cholecystectomy.
Top it. I really like that. But explain what it actually means. You don't take the whole gallbladder out.
No, you don't. You acknowledge that it is simply too dangerous to remove the bottom part, the part glued to the common bile duct. So you cut the gallbladder in half. You remove the top dome. You scoop out all the gallstones. But you deliberately leave the bottom cuff, which is called Hartmann's pouch, firmly attached.
You leave a piece of the diseased organ inside the patient.
Yes, you do.
Does that feel like a failure to a surgeon?
To a novice, yes, absolutely. They feel like they didn't finish the cholecystectomy. Their ego takes a hit. But the source material is completely adamant about this. This is not failure. It is wisdom.
Because you have to look at the alternative.
Exactly. If you stubbornly try to dissect and remove that last tiny centimeter of inflamed tissue and you accidentally cut the main bile duct, you have ruined that patient's life. If you leave a little bit of gallbladder wall behind, what's the worst that happens?
Well, you tell me. What actually happens to that leftover pit? Does it get infected?
There are two main ways surgeons handle it. You can reconstitute it, which means you sew the leftover cuff completely shut. You basically make a tiny mini gallbladder out of the remnant.
Does that cause problems down the line?
It can. New stones can sometimes reform in that little pouch years later, but it's generally very safe. The other option, if the tissue is too degraded to sew, is to fenestrate it.
Fenestrate. Good SAT word there.
It just means to make a window or to leave it wide open. You use cautery to burn the inside lining of the mucosa so it stops producing mucus and slime. You make sure you take out all the stones, and you just leave the pouch open with a surgical drain tube sitting right next to it.
But won't bile just leak out into their belly?
It might. You might have a controlled bile leak out of the drain for a week or two, but here is the absolute key concept. A bile leak from a tiny duct in the gallbladder wall will heal on its own. A transected common bile duct will never heal.
So TOP, it is the strategic retreat that actually wins the war.
It changes a potential life-ending catastrophe into a minor annoyance that requires a drain for a few days. It is a brilliant, mature surgical move.
Okay, moving further up the ladder, we are at C.
C is convert to open.
The old-fashioned way.
Yeah.
Making a big incision with a scalpel.
Getting your actual hands inside the belly. Getting tactile feedback.
The source quotes a master surgeon saying, "The only surgeons who don't convert are those who don't know they should have."
There is a very real, very dangerous ego trap in laparoscopy. We call it minimally invasive machismo. Surgeons feel like if they have to open the patient up, they have somehow lost the video game.
But the patient on the table doesn't care about the video game.
The patient only wants to be safe.
Okay.
If there is uncontrollable bleeding, or if you suspect you might have nicked the bowel, or if you are just completely confused by the anatomy and totally lost open, stop staring at a 2D screen and get your hands in there. Feel where the stones are. Feel the pulse of the artery.
It's not a defeat. It's an appropriate escalation of care.
Precisely.
All right, O.
O is on-table cholangiography, or IOC.
This is the X-ray option, right?
Yes. If you can find the cystic duct, or at least what you strongly think is the cystic duct, you make a tiny little nick in it. You insert a fine plastic catheter, you inject a radiopic contrast dye, and you use a fluoroscope, which is a live, real-time X-ray machine, to take a picture.
And the dye just lights up the whole biliary tree on the monitor.
It lights up exactly like a road map. You can clearly see the common bile duct. You can see if there are stones hiding in it. You can see if the dye is flowing freely down into the bowel.
So if you're lost in the woods, you basically pull out the GPS.
Exactly. It doesn't fix the anatomical problem, but it defines the anatomy for you. It confirms, yes, this tube is safe to cut. Or it screams, no, that tube is the main duct. Step away immediately.
Which brings us to R.
R is rescue cholecystostomy.
This one sounds like pure damage control.
It is. This is for the patient who is actively dying on the table. Maybe they are severely septic, their heart rate is 140, their blood pressure is tanking. The gallbladder is just a gangrenous bag of pus. The anesthesiologist looks over the drape at you and says, "You have 10 minutes." Or she arrests.
You obviously can't do a careful, methodical dissection in 10 minutes.
No, you can't. So you bail completely. You stick a heavy tube straight into the gallbladder, either percutaneously through the skin or quickly through your scope. You suck out all the toxic pus, you stitch the drain in place, and you get out.
Wait, you just leave the diseased gallbladder inside them?
You leave the organ. You treat the immediate life-threatening sepsis. You stabilize the sinking ship. You can always come back in 6 weeks or 3 months when the patient is actually healthy and take the gallbladder out then.
Live to fight another day.
It is the ultimate survival move.
And finally, we reach the last rung of the bailout ladder. The absolute bottom of the barrel. D.
Drain, close, refer.
This implies that something bad has already happened.
Or that you realize it is about to happen and you are completely, totally out of your depth. Let's say you identify a bile duct injury. You see bright yellow bile pouring out of a tubular structure that definitely shouldn't be leaking.
The ultimate stomach drop moment for a surgeon.
The immediate instinct, human nature, is to try and fix it. I broke it, I need to fix it.
But the ladder explicitly says refer.
Do not try to fix it. Put a soft drain in the area, close the skin up, wake the patient up, and send them to a specialist.
We are going to talk about the golden rule associated with this D in just a minute because the hard date on that is actually shocking.
Yeah.
But first, let's go back to the pathology for a second. We mentioned Mirizzi syndrome earlier.
Ah, yes. The stone that eats the duct.
It seriously sounds like a 1950s horror movie title. Let's explain the Cisendi's classification from the source. It's based on this terrifying concept that the fistula grows.
Right. Imagine a massive, hard gallstone stuck tight in the neck of the gallbladder. It is physically pressing hard against the adjacent common hepatic duct. Compression only. There is no hole yet. It's just squeezing the main duct shut from the outside, causing jaundice.
Tip 2.
The relentless pressure cuts off the blood supply. The wall of the duct dies. That's necrosis. A hole forms between the gallbladder and the duct, a fistula. Type 2 means that hole involves less than 1/3 of the circumference of the main duct.
Type 3.
The stone keeps pushing. The hole gets bigger. Now, up to 2/3 of the duct wall is completely gone, destroyed.
Type 4.
Complete destruction. The entire wall of the bile duct has eroded away. The gallbladder and the main duct have essentially merged into one giant inflamed cavity.
And type V, what could be worse than that?
Type V is all of the above, plus the fistula has now eroded into the bowel or the stomach. The gallstone has literally chewed its way into the digestive tract. It's a total unmitigated disaster.
The implication here for the surgeon is huge, right? If you have a type 5E Mirizzi and you just grab the gallbladder and try to pull it off,
You are pulling the entire bile duct out with it. You end up with a massive, unbridgeable gap in the main biliary tree. You can't just stitch that back together. You need what's called a Roux-en-Y hepatocoagulopathy.
just translate that for us.
Major reconstruction. You have to bring a loop of small intestine all the way up and surgically create a brand new connection directly to the tiny ducts right at the base of the liver hilum. It is a highly complex 4-hour operation that requires specialized fellowship-level skills.
Which brings us directly to the classification of the injuries themselves. If you ignore the signs, if you don't use the bailout ladder and you cause an injury, how do we grade it? The source uses the Strasbourg classification for bile duct injuries.
The mnemonic for this one is a bit can damage everything. A, B, C, D, E.
Let's run through them. Type A.
Type A is a relatively minor leak. It's usually leaking from the cystic duct stump, maybe a metal clip slipped off, or from these tiny accessory ducts in the liver bed called ducts of Luschka.
Is it fixable?
Usually yes, and often without more surgery. You send them to GI, they do an ERCP, which is a scope down the throat into the stomach. They put a temporary plastic stent in the duct to lower the pressure, and the leak just seals up on its own.
Type B, a bed can damage. So B is for a blocked.
An aberrant duct is blocked. You mistakenly clipped a branch that was draining a whole sector of the liver, thinking it was the cystic duct. Interestingly, the patient might not even know right away, but over time, that isolated part of the liver will atrophy and shrink.
Type C.
An aberrant duct is cut, so instead of clipping it, you snipped it. Now it is actively leaking pure bile directly into the belly cavity. That definitely needs fixing.
Type D.
Lateral damage. You nicked the side of the main duct with your scissors or cautery hook. You didn't cut all the way through the pipe, but you burned a hole in the side of it.
And finally, type E, everything.
Everything divided. Complete transection of the common bile duct. This is the ultimate catastrophe we've been talking about. It is further graded E1 all the way to E5 based on exactly how high up the injury is towards the liver.
With E5 being the absolute worst case.
E5 involves injury to the right hepatic duct way up inside the liver tissue itself. It is exquisitely difficult to repair, even for the best experts in the world.
The statistics on this in the source material are deeply sobering. The incidence is 0.3 to 0.5% in laparoscopic cases, which is actually higher than in the old days of open surgery.
It sounds like a tiny fraction, but you have to think about the sheer volume. We do roughly 750,000 gallbladder removals a year in the U.S. alone. That translates to thousands of major injuries every single year.
And for those specific patients, it is 100% of their reality.
Exactly. And the real tragedy is that most of them are entirely preventable. They aren't just bad luck, they are cognitive errors, errors of perception and judgment.
Which brings us full circle back to that golden rule of drain, close, refer. Why is the source so incredibly adamant about not trying to fix the injury yourself when you realize you made the cut?
Because this is backed by hard, unforgiving data. Large studies clearly show that bile duct repairs attempted by the primary general surgeon at the immediate time of the injury have significantly worse long-term outcomes than repairs done later by a specialist.
Why is that? Is it just because the general surgeon isn't manually skilled enough?
It's a complex combination of technical skill, the physical environment, and the surgeon's psychology. Think about the scene again. It's 2 a.m. You are physically exhausted. You have just realized you made a terrible, life-altering mistake on a patient. You are panicked. You are overwhelmed with guilt.
You are totally emotionally compromised.
Completely. Your hands are probably shaking. You are in the absolute worst possible headspace to perform incredibly delicate, high-stakes microsurgery. Plus, biologically, the tissue is highly inflamed, it's torn, and it's currently filled with caustic bile. The tiny stitches you try to place simply won't hold.
So if you stubbornly try to sew it back together right then and there,
it falls apart a few days later. The duct scars down in strictures. The patient gets horribly infected. They need more, much harder surgery. Or in the worst cases, they end up needing a full liver transplant.
Whereas if you just swallow your pride and put a drain in.
You turn a chaotic disaster into a controlled, stable situation. The leaking bile safely drains into a plastic bag. The patient wakes up. You treat any infection with IV antibiotics, and you safely transfer them to a dedicated hepatobiliary center of excellence.
And then what happens a week later?
A fresh team, well-rested, unburdened by the guilt of the initial injury with all the right specialized equipment, goes in. The acute inflammation has had time to settle down. They perform a perfect, tension-free reconstruction. The patient's long-term survival rate skyrockets.
So the true hero move isn't doing the complex, fancy sketching. The hero move is having the humility to admit you need help.
Drain, close, refer. It literally saves lives.
We have covered so much ground today. All the way from that terrifying 2 a.m. bleeding field to the brilliance of the FAT Campaign mnemonic for predicting trouble.
We systematically climbed the sift cord bailout ladder. We thoroughly dissected the binary nature of the critical view of safety.
I want to wrap this up with the core philosophy behind this deep dive. The source material ends with a really powerful lingering thought. It says, the best surgeons are defined by the cases where things went wrong, and they made the right call.
Because it's easy to look like a rock star when the anatomy is absolutely perfect. Any junior resident can take out an easy textbook gallbladder.
But when that gallbladder wall is 5 millimeters thick, and the hepatocystic triangle is frozen solid, and the clock is ticking.
That is precisely when you earn your title as an attending surgeon. By stopping your hands. By deciding to do a subtotal. By actually listening to your scrub nurse when she asks a question.
Mrs. Fatima A. got to go home to her grandkids entirely because her surgical team followed these exact rules. They didn't let their ego drive the operation into a ditch.
They prioritized sound clinical judgment over blind manual skill.
So, to all of you listening, whether you are actually scrubbing into the OR tomorrow morning, or you are just navigating your own high-stakes, pressurized decisions in business or your personal life, I want you to remember the lesson of the bailout ladder. Because sometimes the absolute bravest, most definitive action you can take is simply to stop.
Study hard, operate safe, and leave your ego at the scrub sink.
And as a final thought to leave you with, think about the psychological aftermath for the surgeon who does guard an injury. They often call it the second victim syndrome. The patient suffers physically, but the surgeon carries that ghost into every single operation for the rest of their career. Mastering these bailout strategies isn't just about saving the patient on the table today, it's about saving the surgeon's ability to heal the next 1,000 patients tomorrow. Always, always check your critical view. Thanks for joining us on this deep dive.